So good morning. Thank you, Dr. Srinivas Reddy, for inviting me to this conference. Okay, sorry about that. So, encephalopathy, you already had a talk, so I will try not to discuss the same things over again. So this is a case we dealt with 3-4 years ago, 57-year-old NASH cirrhosis, and he presented to us with a few weeks of chronic progressive inability to carry out tasks of daily living. And his bilirubin was marginally high, albumin, INR were marginally deranged. He had minimal ascites. So my question to Dr. Somashekar. So how will you proceed from here?
So looks like, here he is not able to do his day-to-day activities. And level of consciousness, sir?
Yeah, so the patient was conscious, fully conscious.
Fully conscious. But he has some cognitive defect.
Yeah, so I'll put the slide here. So I think, yeah, you are hinting at this patient having chronic encephalopathy.
Yeah.
So like you said, you are interested in the cognitive changes. So he had a slow decline in his memory.
Oh.
He was unable to, his recall of short-term memory was affected. And we did an MMSE score that was around 20. And so that was the cognitive part. And then you are interested in his motor disability. So basically, so there's significant slowing. I'll just play a video shortly. And he was unable to walk without assistance. He was limited to bed most of the time for the last few weeks. He was pretty sarcopenic. He was almost Parkinsonian. The expression was very slow. There was increased muscle tone and everything. And then he was withdrawn. There was some personality change, and he had these comorbidities.
Yeah. So generally,
so how will you grade?
Yeah. See, traditionally we talk about West Haven grading, but that applies for episodic hepatic encephalopathy. But here it looks like he's going into chronic hepatic encephalopathy, where we need something else other than our just West Haven grading. So we need to stage these people with other scoring systems other than our West Haven, traditional West Haven and chess scoring system.
Okay. So like you said, the traditional West Haven scoring grades 1 to 4, it is typically for episodic HE. So you have your cirrhotic who is stable, who is now traditionally in hepatic coma. So mentation has to be depressed. So these don't specifically tell you about this group of patients. This patient has chronic HE. He's fully conscious, fully alert, but then his cognitive abilities are disturbed. So you're looking at these batteries of cognitive tests. 90% of the times you don't have to do this, but this is for the chronic persistent HE types. So these are tests of attention deficit and slow information processing. And then so he was slow in all of these. And then we did a functional impact score. This is activities of daily living. He was significantly impacted. So he was pretty slow. There was cognitive decline, and he was not able to carry out activities of daily living. Just quickly play a video here. So this was a patient. We were trying to do a number connection test with him. I'm sorry, the audio is not coming through. So there's hardly any motor movement happening. We actually asked him we wrote a number and asked him to identify the number. It's like 30 seconds, and we didn't get an answer from the patient. So that was the state of affairs. He was bedbound. And so basically what we have here is this 57-year-old with significant persistent HE affecting his motor and cognitive ability. So Dr. Sridhar, so we optimized the traditional correctable factors, lactulose, rifaximin, we gave the branch chain amino acids. His sodium was 125. How will you deal with that?
How much? Sodium is?
125.
Yeah. So like as all the patients with it, one of the factor in this patient with hepatic encephalopathy probably hyponatremia, which is chronic, mostly hypervolemic is a contributing factor, not the sole factor. And like ideally, suppose if this patient is on symptoms like apart from your routine therapy of fluid restriction and stopping the diuretics, suppose if the patient is already on diuretics, correcting the hypokalemia if the patient is hypokalemia.
So assuming this patient has hypotonic hyponatremia, he is not on diuretics, how will you now deal with this hyponatremia?
So these patients per se, suppose long-term tolvaptan role is very minimal. Like in this patient, 3% saline is not indicated. Tolvaptan, suppose if the patient is going for transplant in another 2 weeks or 3 weeks, that is the role of tolvaptan. Otherwise, tolvaptan effect is short-lived, and there are some studies where liver dysfunction may be increased. But tolvaptan in a short time, it increases the quality of life, and your after hyponatremia correction, these hepatic encephalopathy symptoms also improves in some patients.
Yeah.
So as of now indicated if the patient is for planning for transplant.
Yeah, sure. So his sodium was right on the cusp, it was 125. There are a couple of cautions about tolvaptan. If you look at the product labeling and if you look at FDA guidelines, you're supposed to give the first dose in hospital, keep them in for 24 hours. Some people can have a jump of 10, 12 milliequivalents in a day. Start slow and avoid it in child C cirrhosis. It's a bit of a paradox, but those are the patients who need it the most. But you have to be very careful when using it in child C cirrhosis. I'll skip the albumin part. Dr. Chowdhury has addressed that. So Dr. Ravi, so what were your concerns with this patient? Because he was the operating surgeon, our transplant surgeon. So we had this patient who was in a pretty neurologically debilitated state.
Yeah. So there are few things we need to look into in these kind of patients. First thing is whether his previous mental health was optimum or not. Whether this is a chronic encephalopathy with a cognitive dysfunction, you are worried that post-transplant, whether his cognitive functions will come back to 100% normal or will partially recover or some residual dysfunction will remain. So that would be one of the main things. So I might ask help of neurologists.
So when you look at this MRI scan with pretty significant atrophy and you look at the patient with neurological debility, so like you said, you're concerned that some of this may not reverse. You might actually, have a patient who had a transplant but remains with significant disability. There's a significant disconnect with the liver function, which is not too bad, and the hepatic encephalopathy, which is pretty severe. So in this scenario, we actually asked, ideally you're supposed to get your neuro colleagues also to see this patient. So we asked our neurology colleagues to review this patient, and we got an MRI done. It shows significant atrophy. We asked, actually this patient was from Mumbai, so we asked him to see a neurologist with special interest in neurodegenerative disorders. So this is a concern. These patients with significant cognitive disturbances and some of them having extrapyramidal effects like increased rigidity, decreased movement, you're concerned about degenerative disorders. But there are some differentiating features when you have the scan showing a lot of atrophy. If you have a neurodegenerative disorder, you're more likely to have midbrain atrophy. If it is PSP, for example, you're more likely to have asymmetric atrophy. If it is multisystem atrophy, you may also expect some pontine changes. And you may have no lenticular changes. If you have hyperintensities in the globus pallidus, that goes more in favor of hepatic encephalopathy. So these are some of the more nuanced changes that you might want your neurologist to look at and tell you how much of this is actually hepatic encephalopathy, how much of this is a neurodegenerative disorder, because you don't want to be transplanting a patient who has significant neurodegeneration. It can get very difficult, and so some of the things I mentioned. A lot of these patients, especially if the etiology is alcohol, and now we're transplanting more and more patients in the advanced middle age group around 60, 65, they're all going to have a bit of cerebral atrophy and white matter changes. That should not deter you from proceeding with transplant, but of course you get a thorough neurological review. And if you have these changes in the hyperintensities in the globus pallidus, for example, these hyperintensities, then that gives you more confidence that you're dealing with hepatic encephalopathy. So he was seen by a neurologist. He was actually started on anti-Parkinson's treatment. Some patients with cirrhosis have significant extrapyramidal symptoms and they might have to go on this Parkinson's therapy. So we did a lot of things to this patient. We put him on albumin infusions. We gave him these medications, and we observed him for a period of 3 months before we committed him to a transplant. So none of these actually made a big difference to the patient. In fact, I mean the lactulose and all, the reducing ammonia, your branch chain amino acids, your rifaxamines, these are generally not very effective in the chronic persistent HE. They're more effective with your episodic HEs. So we looked for these large shunts. We didn't find any of these single large shunts. So if you have a single very big shunt, you might consider embolizing the shunt to see if that reverses the encephalopathy before you subject the patient to a transplant. This has its own problems. It can precipitate worsening portal hypertension and it can push the patient into other problems like bleeds, for example. But our patient did not have this. So Dr. Gopi, so now we have a patient who has significant neurological debility and comorbidities. And we went through the whole process of evaluation. We thought there was no coexistent neurodegenerative disorder. We went through the whole discussion with the family and now we are proceeding with transplant. So what are the things you would want to look at as the anesthetist taking charge?
So most common contributors are hemodynamic instability, rapid fluid shifts and rapid correction of sodium. So my priority would be to maintain cerebral perfusion pressure, though autoregulation is fairly maintained in this type of patient, but can have significant derangement during the anhepatic phase and the early neohepatic phase. So hyperperfusion, hypoperfusion, both can cause an issue here. So hemodynamic optimization is very important. Rapid correction of sodium can cause central myelinosis.
So more specifically with regard to this patient, our extubation was pretty delayed. Normally we go for ERAS, the early extubation, or for example, they extubate the next day. For this patient, because of his sarcopenia and encephalopathy, he remained intubated for close to a week. And then after that, we had to actually do a tracheostomy for this patient to facilitate extubation. And so how do you manage delirium? Is that a big delirium or an altered neurological state in the post-operative phase? Is that a concern when you're taking these patients up for surgery?
Yes, definitely. In the immediate, so a lot of microembolic events happen during surgery, which right now we are not picking up because we don't use transcranial Doppler routinely. So, and then optimization of metabolic optimization, correcting hemodynamics, and then sedation breaks and frequent monitoring of delirium. I think non-pharmacological methods are more important here.
Sure. So basically, in green, we have this patient who starts off in a pretty poor physiological state. And then going through surgery, you have all the fluid shifts and ischemia, the blood pressure shifts and reperfusion injury, all the dyselectrolytemias. This can add to the neurological problem. And it can be long lasting. If your hypotension is severe, the neurological recovery, you can push it back by several months. And then you have, once you've transplanted your patient, then you have your immunosuppressive drugs, the CNIs, which can add to the problem. So post-transplant, we gave this patient tacrolimus, and he was getting pretty excitable and tremulous. And at one point we were worried if he was getting additional complications like leukencephalopathy. We repeated the MRI, which was okay, and we put him on a very low dose. So what this patient has is the chronic HE variant. So persistently he is in HE. He used to go into grade 3s and then come back to a grade 1 or grade 2 level, not your regular episodic HE, which is a bit more easier to manage if you have non-provocating factors. And I think one important thing here is if you actually give yourself some time, see these patients, assess them initially, take the help of your neurologist, give them an interval after all your interventions, and if you repeat a scan, it's interesting that some of these patients can mimic have chronic vascular changes like white matter changes, which can reverse once your encephalopathy reduces. So you can take all these measures before you actually plunge into transplant with these patients. So to summarize, so we went through with the transplant, and then after the transplant you have this problem of accelerated atherosclerosis because he already has the risk factors and now you're adding medications to it, and that is actually what makes cognitive recovery worse after transplantation. So you have to take care of your immunosuppression as well and modify your metabolic risk factors. So this is the patient post-transplant. I hope I can get the audio here. This is the last slide. So actually surprisingly we had pretty rapid neurological recovery. This was 3 weeks post-transplant. So you see that, his eye contact and, the way he's talking. I'm sorry about the audio not coming through, but this was 3 weeks post. So the message I have is, if you have somebody with chronic debilitating hepatic encephalopathy, you don't automatically invalidate them. So Metu wanted a complex preoperative case, so I think this was one of the more complex ones. We had to talk to the family, set their expectations. They need to know that they may not come back to full cognition post-transplant. They may not be useful actually, to put it in a certain way, post-transplantation. I think I have Dharmesh at the mic. Hope it's not a difficult question, Dharmesh.
So you presented a great case, Sharath, but I think the message for the audience should be that somebody who's got a sodium of 125 first to see whether they are edematous or not. And then an electrolyte that we often don't give much attention to, that is chloride. So that's something that we don't give much attention to. That can give you a handle on whether you want to correct your electrolytes, but potassium is extremely important. Hypokalemia, which is long-standing, is a very common cause of this, as is hypermagnesemia, very poorly studied electrolyte in the context of liver disease. What you described is a classic...
So the hyperintensity is in the basal ganglia, that is the...
So that is manganese and magnesium, unpublished work done 25 years ago by us, but it's unpublished. So the description of this patient is a chronic persistent HE. The message to this audience is never send this patient to a neurologist. They will almost invariably start this patient on PD medication, so get an MRS done first. And also, every time you have a discord between the degree of liver dysfunction and encephalopathy, we should do a Doppler or an MRV. That should be the first step in the management of a patient like this. Of course, this is not an uncommon problem.
So we did a carotid and vertebral Dopplers for this guy. So he didn't have obstructive atherosclerotic disease.
Yeah, so MRV because you have good liver functions and bad encephalopathy. Of course, ammonia did not figure in your description. I wish it had.
No, I skipped through the ammonia slide. This person's ammonia was around 65. Everything was just on the cusp.
So these patients need a huge period. So what we do in our program is to have a run-in with them rather than try to tackle them later on. So many of them are deconditioned actually. So if he is not edematous, he is hyponatremic, chloride is normal to low, then you know that you are not dealing with the situation where you want to correct that. So these patients need more of a physio-based input after you've ticked the other boxes, and then that's the time we would want to transplant them.
Yeah, so the 3-month waiting that I was talking about, I think we put him through everything, including neuro rehab and some nutritional fortification. So we went through a lot of things, and I skipped some of the slides because it's very tight doing a panel discussion in 15 minutes.
Thank you.